Transfusion safety is really a registered nurse activity, and I just continue to reiterate the blessing of nursing assessment, getting those vitals before the transfusion, and then monitoring them closely and stopping the transfusion if they have a reaction, because that's really an assessment, and we can't delegate that to non-licensed staff. And so that's really why we just celebrate that nurses have such a great role in transfusion safety.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Lanice Taylor, Oncology Clinical Specialist at ONS. Today we're talking with Renee LeBlanc, Manager of the Transfusion Services Office at Fred Hutchinson Cancer Center in Seattle, Washington, about what nurses need to know about administering plasma and cryoprecipitate. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining us today, Renee.
Oh, happy to be here, Lanice. Thanks for having me.
Can you give us some background on what plasma and cryoprecipitate are as blood products?
Yes. Plasma and cryoprecipitate are blood components with a role in hemostasis. Plasma is collected from normal volunteers from a whole blood donation or by apheresis. Whole blood is spun down to separate plasma from red cells. FFP may be more familiar to some nurses for fresh frozen plasma. Plasma is a more universal term now that there are unthawed versions. Plasma contains factors necessary for clot formation, such as factor VIII and factor V. Cryoprecipitate is created by additional processing of fresh frozen plasma. Cryoprecipitate is concentrated fibrinogen. You may recall factors in fibrinogen are elements of the clotting cascade.
That lovely clotting cascade.
Yes. We won't go into that this talk.
That's a good idea.
Okay.
What are the indications for using these products? And at what level would an oncology nurse expect to administer them?
Well, the indications for plasma has changed over the years as safer products are available for volume expansion or coagulation deficiencies when time allows for those treatments to take place, such as vitamin K for warfarin reversal. Changes are also coming from the Joint Commission, who lists blood products as an overused procedure and encourages patient blood management to ensure evidence-based approach for patients who may need a blood transfusion. That said, plasma is still indicated for massive transfusions, emergent reversal of warfarin therapy-related intracranial hemorrhage. Nurses may also see plasma ordered pre-op for multiple coagulation deficiencies or factor XI deficiency. Patients with disseminated intravascular coagulopathy, DIC, due to disease, sepsis, or disease therapy may have low fibrinogen. I've seen patients at risk for cytokine release syndrome monitored with coagulation labs, including fibrinogen. CRS, as you know, is a systemic inflammatory response associated with some CAR T therapies. In severe cases, CRS can be associated with coagulopathy and hypofibrinogenemia, low fibrinogen, requiring a transfusion. Cryoprecipitate is an excellent source of fibrinogen. Actively bleeding patients also come to mind for an indication. Plasma and cryoprecipitate are products that support hemostasis, as we said. Bleeding in the presence of labs that support the need for plasma and cryo would be an INR greater than 2, fibrinogen would be less than 100. Nurses have an important role to quantify blood loss and assess patient vitals, contributing to an early identification of the need for transfusion. If patients are actively bleeding, consider that coagulation deficiencies will prolong the bleeding. Timely replacement of coagulation factors is imperative to establish stable clots. Massive transfusion protocols for patients who are rapidly bleeding, say from tumors invading large vessels, have evolved to guide a balanced ratio of red cells to plasma to decrease coagulation factors that would result if only large numbers of red cells were transfused, such as like if you were to give 4 to 6 units of red cells but not give any plasma products, then all of a sudden you're going to start to see coagulopathy established.
Excellent. You talked a little bit about some of the laboratory tests. Those laboratory tests can often indicate a patient's initial or ongoing need for plasma or cryoprecipitate products. What tests specifically should nurses be reviewing?
Well, the tests to measure coagulation factor deficiencies are prothrombin time, or PT, partial thromboplastin time, PTT, or an INR, internationalized normalized ratio. Protocols consistently recognize an increased PT or PTT values of 5.5 times normal or an INR greater than 1.8 to 2, pairing with the clinical picture, of course, as an indication for transfusing plasma. Cryoprecipitate is indicated when fibrinogen levels are less than 100. Parameters may vary by institution or protocol, and I certainly see cryo transfused when fibrinogen is below 200. Lots of work being done on what is the right level, and depending on the situation, how fast you're going to get cryo. Some providers might be conservative and say, I don't want to wait till it's less than 100 before we transfuse.
That totally makes sense. What kind of settings can plasma and cryoprecipitate be administered in, and how are the settings different depending on the indication?
Well, the settings for transfusing plasma and cryo, an infusion clinic, considering that plasma needs to be transfused close to the time of a procedure, an infusion center not affiliated with a hospital or medical center that performs emergent and basic procedures may not be set up for transfusing cryo or plasma. For those locations that are, good communication and coordination with the procedure team to ensure timely transfusion close to the procedure will be key. Cryoprecipitate similarly requires a transfusion center set up for this specialty product, and not all transfusion services stock cryo. A large hospital with an on-site transfusion service is a setting that will be more familiar with these products, especially if they serve a patient population that might be at risk for a massive transfusion or an OB hemorrhage. Nurses in these settings are more likely to encounter these products. Surgical centers performing procedures with large volume blood loss would be a prime location for staff to be experts in transfusing plasma and cryo. Nurses caring for patients with cytokine release syndrome may be familiar with monitoring for hypofibrinogenemia. Cryoprecipitate in this setting may be given more prophylactically than for a patient who's actively bleeding or having a procedure. Patients who have Wallström's macroglobulinemia, this is a type of non-Hodgkin's lymphoma that causes large amounts of IgM, resulting in damage to the blood vessels, which may lead to excessive bleeding. I've seen patients giving plasma in the clinic for these patients.
That's a lot to think of. So I think nurses may encounter plasma and cryoprecipitate less frequently than other blood products like red blood cells or platelets. But how is the administration maybe similar to and then maybe different from the more common blood products?
I agree, Lenice. Plasma and cryoprecipitate are not frequently transfused in the oncology setting. Oncology nurses, as you said, are more familiar with red blood cells and platelet transfusions. Fortunately for nursing, much is the same for routine transfusion. What is the same? Well, one, a valid consent is still required. Note, some Jehovah's Witness patients may accept plasma or cryoprecipitate. Refer to your bloodless program for how that's managed. Two, I would expect transfusion service to require an ABO type on file for non-emergent plasma transfusions. Nurses continue to check each unit to ensure the right patient has the right product. Fourth, I would think that nurses should continue to transfuse with blood tubing with a micron filter. And for routine transfusions, the transfusion rate would start slowly for each unit. After the initial observation period can be adjusted per local policy to increase the rate. Six, nurses would continue to assess the patient for reactions before, during, and after each unit. Remember, each unit is a unique exposure, requiring the same process to assess tolerance. Continue to stop the transfusion if there are signs of a reaction and report all transfusion reactions to the blood bank. Last, educating the patient and caregiver about reporting and reaction symptoms as soon as possible, and provide discharge instructions if they're not continuing to be observed after the transfusion. These are still important aspects of transfusing these products safely. Now, what's different? A repeat type and screen is not needed for plasma and cryo, just an ABO type on file. RH type does not apply to plasma or cryo. The D or RH antigen is on the surface of red cells, and there are no red cells in plasma or cryo. Plasma is not a concentrate, and the adult dosage is dosed at 10 to 20 milliliters per kilogram to increase factor levels by 10 to 25%. In a 70 kilogram patient, that'll be around 4 units or bags of plasma. So a lot more plasma bags are transfused than you would typically see in a platelet or a red cell transfusion. For adults, cryoprecipitate is pooled with 5 to 6 units to make an adult dose and raise the fibrinogen 40 to 45 milligrams per deciliter. 2 cryo doses may be needed for some patients. And you'll notice the total volume is quite a bit smaller than a regular red cell unit at 350 mils. It'll be a little bit closer to 120, 25 mils.
I was just trying to wrap my brain around what that volume looked like and then how quickly you're going to be running it in or how slowly, and looking at volume overload and all of that sort of thing. It was a lot to think about.
Exactly. Well, and so plasma, when you're giving 4 units, that's a little bit more time commitment, a couple of hours, whereas cryo, it's a smaller unit, it's about half the size. It's going to whip in about a half hour. So yeah, really different experience in that regard.
Very much so. So you mentioned a little bit earlier when we were talking about settings, about the timing of when you would administer these. So we know it's an important factor. What do nurses need to know about when these products are administered as it relates to care coordination and the expiration of the products?
Really good points. Plasma coagulation factors have a short half-life. Transfusing as close to the procedure will ensure the highest level of factor activity at the time of the procedure. Nurses can ensure best outcome through care coordination, timing the transfusions as close to the procedure as possible. So we don't want to start transfusing plasma at midnight if the factors are going to be expiring and their procedure isn't until 9 o'clock in the morning. So we really want to be giving the plasma, starting it and running it right up to the time of the procedure. So again, if you're in a clinic that's far away from a procedure center, it might not be the best option for the patient to be coming into that clinic. You really want to have it in the procedure center. Cryo is thought as single units and pooled at the time of transfusion will have a short out date. So once we open up a system and start to pool it, then we typically are going to see those units expiring within 4 hours after the system was opened up. So meaning that nurses need to coordinate the patient care activities to ensure the products arrive at the bedside before it expires. Solid plasma and cryo also have a limited shelf life. And this is important for nurses then to notify the transfusion service if the order is canceled, so the products can be unallocated and transfused to other patients.
I think going back to the short out date with the cryo, I think that's one of those things that always gets interesting in the conversation about, is that out date, is that time when you're supposed to actually have the bag finished, or is it the time when you start it?
Yes, so the circular of information has changed over the years, and now the circular of information reads that you need to start the transfusion before it expires. So that's a great question.
What education do nurses need to provide to patients receiving plasma or cryoprecipitate?
As with any transfusion, patients should be encouraged to notify the nurse as soon as possible if they're experiencing any new symptom or changes to existing symptoms. Nurses can minimize transfusion reaction severity by stopping transfusion when the reaction is recognized. Whenever a patient is discharged shortly after receiving a transfusion, they should be given instructions and contact information for what symptoms warrant calling and who to call after hours, for example. Transfusion reactions such as volume overload can still manifest up to 6 hours after a transfusion. Considering that plasma transfusions consist of 3 to 4 units in our patients with pre-existing comorbidities, not to exclude a low ejection fraction, it is imperative that nurses provide clear transfusion discharge instructions.
That's such a good thing to remember, that it's not just, you made it through the blood product administration and you did fine with it, and now you can just go home. There's more things that they're going to have to look out for when they go home.
Absolutely. I've reviewed transfusion reaction cases where patients are in their driveway and all of a sudden they're having acute respiratory distress and they're calling 911 and back to the ER they go. But, if you look at those patient histories, you're not necessarily surprised. It's like, oh, their ejection fraction is 25, or they're elderly, and these are all risk factors for transfusion-associated circulatory overload.
Renee, this has been very informative and really good to bring to the forefront, especially for those of us who may not see these products very often. Is there something else you'd like to add?
Well, I just think that nurses need to remember that they may not be as familiar with plasma or cryo, but oncology nurses in general are experts in routine platelet and red cell transfusions, so much is the same. Hopefully today we gave them some insight into labs associated with these products and tips about the timing to increase their confidence.
I very definitely think that you have. I have just a few more questions for you. What are some common misconceptions about plasma and cryoprecipitate?
Well, it's been lovely for nurses to educate me over the years. And one of the questions that I get sometimes, especially with plasma, is like, I don't have time to be at the bedside for 15 minutes for 4 units. That's an hour of time. So that's why I just remember that each unit is a different donor, and what they ate, what kind of antibodies they have, whether they were pregnant, is all part of that experience. It's not the same plasma product given 4 different times or 3 different times. And so just really drawing nurses into the value of being at the bedside for that first 15 minutes is that final determination of acceptability and tolerance. And truth be told, as that immune system starts to wake up, especially in our cancer patients who have dysregulated immune systems, when they start seeing all those cytokines and proteins that are swimming in plasma, their immune system might be starting to get more challenged as we get to bag 3 and 4. So we really want more monitoring over time with these products, not less.
Wow. That really brings it home, especially talking about how each one of those products is from a different donor, but then adding in the component about maybe even to the point of what they ate that day when it was collected.
Yeah. Isn't that amazing? It's strawberry season.
What's something about this topic that's not often discussed, but you wish people knew more about?
So for those of us who are in the transfusion world, patient blood management has been talked about for certainly a decade, but I think it continues to become more and more incorporated into our discussions in the hospital, especially as we have less donors. We're trying to minimize exposure. So just appreciating that we are really trying to make sure that patients have an indication for their transfusion and that's appropriate. So again, that care coordination, we don't want to expose a patient to 4 units of plasma, but we gave it way too early and then it's not really effective and we need to reschedule. So we just really want to make sure that we're all doing our best to transfuse when it's needed, and then doing everything we can to make sure that we don't overexpose patients to transfusions if they don't need a transfusion.
Excellent points. What additional training or education do oncology nurses need to stay current on this topic?
Well, the American Association of Blood Bankers, AABB.org, certainly has wonderful resources, and even about patient blood management. So I would certainly direct nurses to that website.
And we will link that in our show notes. What are some additional resources for patients or other members of the cancer care team who want to learn more?
Well, and even for nurses, the other great resource is the Blood Bank Guy. He does a lot of great podcasts, so I think that's another great resource. And also the Circular of Information, I guess, for nurses would be another great place. The American Society for Oncology would certainly be a place that patients could go to as well.
Like I said, Renee, this has been great having this conversation with you. Do you have any final comments for us?
Monitor, monitor, monitor. Transfusion safety is really a registered nurse activity. And I just continue to reiterate the blessing of nursing assessment, getting those vitals before the transfusion, and then monitoring them closely and stopping the transfusion if they have a reaction, because that's really an assessment. And we can't delegate that to non-licensed staff. And so that's really why we just celebrate that nurses have such a great role in transfusion safety.
Thank you so much for joining us today and for sharing your knowledge.
Thank you so much.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.